34 at subsequent screening. And although their stage data wasn't quite as positive as that of the LCAP investigators or the Japanese groups, still a 61% stage 1 is certainly reasonable. But they did have a higher stage 3 and 4 rate than was anticipated, with 3 and 4 stages representing about a third of the cancers that were detected. A couple years ago, Swenson and colleagues did look at their mortality rate in the Incidence trial and compared it to the original Mayo Lung Project and saw no significant difference in lung cancer mortality rates. So a little bit of sobering news there. More recently, the LCAP has really expanded. Claudia Hinchke has expanded to over 30 countries of people who are involved in screening really all across the globe. And they have published in the New England Journal of Medicine their results of over 30,000 people who were screened using their protocol. You can see the lung cancer prevalence was about 1.5%, and they had the same percentage of stage 1 cancers as they did in their early investigation that was just done in New York. This article is probably familiar to everyone here. I think some of the highlights of it is that it was international. It was done at both academic and private practice settings. They maintained that high level of stage 1 cancers, and with their modeling, they estimated a 10-year survival of 88%. Well, what have we learned from the international LCAP data? Well, I think it certainly confirms the results of these smaller studies that CT screen-detected lung cancers are mostly early stage with a high survival rate. I think it also shows that this is something that can be transferable outside of a prestigious academic center in New York, that it can be done internationally and it can be done in the private office as well as in the academic domain. Their survival data is very compelling, but I think that what's really important is that we need to answer the question about, does screening reduce lung cancer-specific mortality? So really that, I think, is a major challenge right now facing us with low-dose CT. I'll talk about other challenges briefly, but the one I want to highlight is the lack of data regarding mortality benefit. And certainly the single-arm trials have done a tremendous amount. I'm very positive about the work that they've shared and what they've done, but the time is now, and hopefully we'll have the data soon, to determine whether or not there is in fact a mortality benefit. Just briefly, obviously, randomized control trial, you want two populations that are matched, one screened with the study, one not screened with the study, and you're going to be looking at the number of deaths from lung cancer in each population. The study that I've been involved in, as Mac has said, is a national lung cancer screening trial, which seeks to answer the question of whether screening with low-dose helical CT reduces lung cancer-specific mortality relative to screening with a chest radiograph. The goal was to enroll over 50,000 smokers and former smokers, and to look for it was powered to look for a 20% reduction in lung cancer-specific mortality. The enrollment ended in 2004 with over 50,000. We exceeded our goals for representation of minorities and different ethnicities. All participants have completed the baseline plus 2 annual screenings as of 2006. The medical record collection is ongoing through 2010, including death certificates for all deaths, vital status and cause of death obtained on all participants, and the primary outcome of cumulative lung cancer mortality is to be reported in 2011. We will see in 2010 the results of baseline screening published. This slide showing each of you the data available so far from the NLST is courtesy of the NLST Data Safety Monitoring Board. You'll see it's a blank slide, and it's because they've really been holding on to that data tight. There were great concerns about the possibility of contamination, crossover, and so forth. So we really are just going to have to be patient and wait. I will show you briefly the experimental design, and then I will show you some results from the Nelson trial, which is ongoing, and it has had a different philosophy about sharing data as early as possible. So high-risk smokers with over 30 pack years randomized to experimental and control arms. Very controversial that the control arm did get chest x-ray screening. Both underwent spirometry, specimens for future biomarker analysis, and everyone's followed up every 6 months through 2010. The CT scanners were all done with state-of-the-art multi-slice technology, a very low-dose technique that's less than annual background exposure. This is an example of the typical cancers we're seeing on a CT screening, small, peripheral often, and usually an adenocarcinoma type. The chest radiographs were just a single view. They could be done with any type of radiographic equipment. At my site, we were using state-of-the-art digital radiography and a much lower dose, obviously, than the CT scan. I'm not sure how well you're going to see this, but just I think you'll see it better on the CT. This is an example of a positive chest radiograph, and again, a peripheral lesion identified in this particular individual a little bit larger than we saw on the CT scan of the other participant. So let's talk about a trial that does have some data and that is ongoing, and that is the Nelson trial. This is an ongoing multi-center trial in the Netherlands and Belgium that's enrolled over 15,000 smokers and former smokers, and are combining their results with 4,000 participants scanned in Denmark. In this study, the control group gets absolutely no screening, so it's a true randomization to CT versus no screening. They get 3 rounds of screening, the prevalence screen, and then 2 annual incidence screens. Instead of the NLST being at 1 and 2 years, this is at 1 and 3 years. And the unique features of this trial are a population registry was used for recruitment. The control arm, as I mentioned, has no screening. They're using volumetric rather than the typical bidirectional measurements of growth of nodules. And they're having a 10-year follow-up. So their interim results are to be published this year, and their final results with a goal of 2015. So let's talk a little bit about some more of these current challenges in terms of the initial high false positive rate for screening. This can be anywhere from 23% to over 50%. We heard that term skanxiety this morning, so just keep in mind that once you get a positive scan, many people will be anxious. There are financial and psychological costs. I think a lot of the initial concerns about the high false positive rate have actually been addressed, because as we're learning about these small nodules, we've really had a paradigm shift in how we're identifying them, calling them positive or not positive, based mainly on size. So this early algorithm of 3, 6, 12, 24 months has really been thrown out the window, because we know that the majority of these very small nodules are benign. We know a lot about the biology of lung cancer with variable growth rates. And there have been concerns, very valid concerns, about not wanting to follow up patients with a lot of follow-up scans, because you don't want to put people at risk of developing another cancer, such as breast cancer in women. We know, this is from Mayo Clinic data, that these very small nodules have a very low likelihood of malignancy, even in a high-risk group of smokers. Dr. Hinchke and colleagues taught us a lot by looking at the people who, in their trial, who had the nodules of less than 5 millimeters, and they showed that there were no cases, even in their high-risk group, in which malignancy was detected within a year. So they've really have shifted this need for follow-up before a year in nodules that are under 5 millimeters. So what's really helped with the false positive is the idea of instituting a threshold size. It was 4 millimeters in NLST, it's 5 millimeters for LCAP, but where you basically treat that as a negative finding, you'll look at it again in a year, but you don't call it a positive screening result. The other thing that's been helpful in the Nelson trial is identifying features other than size that predict benignancy. So if we look at the Nelson trial data, although over 50% of participants had more than one nodule or one nodule at baseline, using those size criteria, they were able to really get down their positive rate to a little over 2.5% at baseline. If we look at the results of their prevalence scan, they had a 0.9% prevalence of lung cancer. 73% of these were resectable, 64% stage 1. At their annual screen, they had an 80% resectability rate, 74% stage 1, and about 25 patients underwent resection for benign lesions. That was only